So hi, I'm Becki, and I just wanted to tell you about my story that's personal to cancer and fertility. So I wanted to save my fertility but wasn't given the chance, even though there was enough time and it wasn't detrimental to my health. So that's why I started the campaign, the Vicious Cycle campaign. And I wanted to involve people like Channa and other health professionals to make sure that all cancer patients, whatever their choice, are getting a choice. So now what we're going to do is the myth-busting questions. So if I let you go first,
okay.
Maybe for young adults.
Okay, right, so here we go. Okay, so the only cancer treatment option I have is the one offered to me by my doctor, even if it makes me infertile.
No, there's always, you can always get a second opinion if there is other options out there. And if it does make you infertile, you've always got the choice to decide for or against it, regardless of what other people think. It should always come down to the young adult to decide what's best for them. So the one for you, for the health professionals,
okay.
This is one of the myths. So if she or he already has children, so they don't need to think about fertility options.
Yes, and I mean that is a complete misconception, because of course, you know, you can flip it around to the people who've already had children. It's natural for people to want more than one child, and they're no less likely to want to think about fertility options, and probably more so.
Yeah, I think it's a complex, isn't it? Kind of, because everyone has their own feelings, so you can't really say one group of people will, just because they have kids, won't want more.
Absolutely.
And it's a loss, I suppose, if you do become infertile.
Yeah, and it's also important to be sensitive to the fact that people may actually, you know, have kids by a previous relationship. So unless you ask them, then you know they may well think it's people may well have kids from a previous relationship. So it's really important to actually ask whether their kids are from their current relationship and whether they want fertility plans in the future with their new partner. Okay.
Yep.
So another question: treatment always makes you infertile. So such as chemotherapy, radiotherapy, surgery, and total body irradiation and hormones. So
this myth, there's always going to be some for different types of treatment that won't get infertile. And that's why with my campaign and also with Trekstock, it's about raising awareness of the ones that will. Things like if it's in your pelvic area or certain chemo drugs. So obviously there will always be some people that won't get infertile.
Yeah. So there's the risk, but it doesn't mean it's certain.
Yeah.
Yeah.
So your myth is, for single women, men, fertility isn't an issue, so why discuss it at all?
Right, okay. So that can be a really common misconception, but of course we're trying to ensure people for the future.
Yeah.
And that's why it's so important to actually offer the choice of egg freezing or sperm freezing, so that in the future their plans may change. So I mean, I think that's a real myth that we need to knock on the head.
Definitely.
Okay. Okay, so here's another one. My fertility level after treatment is going to be the same forever.
No, it can change for certain people, and that's why it's good, like you said, to have the blood test to see. So if like myself, I've gone through, like the word you don't like, menopause, but gone through that. But there'll also be other people that it'll just be temporary, and their fertility will improve. Like you said, when they get periods, it will get better with time. So there's always different cases. Yeah. So you always have to make sure that you ask your oncologist or what specifically for you what it is. So your myth is, they are too young to talk about fertility options with them. I won't bring it up.
Oh, okay. So, and this is such a tragedy, because we know, from studies that sometimes up to half of patients, this study was done in America, aren't given the discussion and options, to actually preserve their sperm in that study's case, or obviously sperm or eggs. And it's really important not to discriminate. People who may be in their early 20s, and we now know that the average age of parenthood is first parenthood is in your 30s in the UK. So it's so important to actually make sure that you discuss with people, regardless of whether they're single, whether they're and young, or they're settled and they have a partner in the long term. Yeah. Okay. Sorry, I can't read this.
Prediction?
Is the prediction of the oncologist always right?
Well, I suppose it's science, isn't it? So if it's to do with their cancer, you can't always be 100%. There can be maybe 99%, but there's always that chance of something. And I suppose the same with fertility as well, that there's always a risk that it might, but I suppose that's why we're given the risks, so we can make kind of decisions.
Yeah, I quite agree. I mean, I think if it's all about advising the patient about risks, isn't it, and giving them options, and then making a shared decision rather than telling people, you don't want a one-way street where we're saying this is what is available to you and we won't do this. It's all about actually trying to inform our patients.
This will definitely happen, so it's good to kind of give a wide opinion of things that could or not happen to each person. So for you, beating the cancer quickly is the most important goal for my patient, so I should consider that the top priority when planning the treatment plan. Yeah,
so clearly it's obviously very important, acute cancer treatments and survival. I don't think that's a reason to forget about fertility treatment as well. So I think the two can go hand in hand. Clearly there's a priority, and the reason we're in the room is that we know that cancer treatment can increase your risk of infertility. But I think it should be. I really want to encourage clinicians out there to really always think about it and always make the patient aware of it.
Especially when there's a chance for some people. I don't need. Is that yours? Sorry. It's all right. I don't need to talk about contraceptives. With my patients during treatment. They won't be having sex then.
So people do have sex, and they are allowed to have sex, and people, cancer survivors, and obviously, we know that some patients with cancer will not be rendered infertile. So it's entirely possible. Shortly after cancer therapy, that you could get pregnant. And there is this risk of, shortly after cancer treatment, that the effects of the drugs would still be on board, and therefore it's not the best time to conceive. So it's really important to discuss contraceptive options in patients, absolutely, who are undergoing cancer treatment, whatever. Cancer treatment induced menopause will mean I will never get my period again.
Well, I know from my own personal experience, in theory, if I didn't have HRT, I could still have my periods. So, and there are other people who, when you do get the HRT, it stops. So, I suppose it's.
But do you think that, I guess, if people have been told they got the menopause, maybe sort of saying, will that ever reverse?
I think, like when you were saying earlier, that when you give it that time gap, that if your periods do come back, that's a really great sign that things are working. It's just having that time to see, will things change? And then someone like myself, if it doesn't, then you go on HRT and then you kind of resolve that. But that doesn't mean you can't have children in the future if you're just temporary, your periods are starting to come back. So there's that window of recovery, maybe within the first 5 years, at which there is potential for the menopause recovery. And then it will go down. Sorry. Getting it wrong. They haven't brought up fertility, so this obviously is not a priority for them. So it's really important to be proactive as a clinician treating people undergoing cancer treatment, to always bring it up, because clearly it's a huge life event, and there may be a million and one things going through your patient's mind. So I think the burden is on us as the doctor to always mention it and also bring it up. I agree with, because also if you're not like me and know, doesn't mean you can't change your mind. So Absolutely. It's good to always bring it up. Okay. Even if I do not get pregnant, the health of my unborn child is at risk. Even if I do get pregnant, the health of my unborn child is at risk. So is that in? You can both answer that. Oh, so is that? Are you asking about after IVF or just in general when? Sort of maybe after getting pregnant, sort of following cancer therapy, maybe. Yeah. I think like you said, wasn't it before, that you have the risk of chemotherapy, that you wait a little while, yes. And then, but after that.
So we know a lot more about because obviously for men, sperm freezing has been around a long time, and we know that sperm freezing is very safe. Using sperm samples that have been collected, used from men, who've had cancer therapy, is still very, very safe. Are there any theoretical increased risks during that pregnancy? Probably yes, but by and large, if you get pregnant, fingers crossed, things are going to be okay.
What about for a patient who hasn't gone through saving their eggs or sperm and freezing, but they've had a baby after chemotherapy and worried? What would you say to them? That they're worried about the effects if it has on their body. What would it do to a child? So
I would say first of all, we don't really have all the evidence in place there, and it's really important to, as you would do during a kind of an antenatal, follow-up, to actually have regular scans, regular appointments to follow the progress of the baby. And the thing is, pregnancy has lots of inbuilt mechanisms. Nature builds in these mechanisms, so that if a pregnancy lasts, there's a good chance, that your baby's going to be fine. That's what I would say.
Yeah. And the last one for me is, cancer patients are already so worried. Talking about fertility adds unnecessary stress to them.
Yeah, and I think that follows on from our previous point, that it's very important not to be too paternalistic as doctors and think that we know best, and we're advisors and we obviously know about the technical aspects, but I do not know you as the patient about what your hopes and wishes and plans are for the future and having a family if you want to. So we really always need to not shy away from these difficult issues and conversations and really deal with them head on.
Definitely.
Yeah.
So thank you again for the myths busting today with us, and we really appreciate your time today.
Thanks again.